is this muscle? Bulbospongiosus. Okay? And the superficial transverse perineal muscle. Those are the main muscles that are cut when you perform a mediolateral episiotomy. So we asked the same question to 75 doctors who were qualified for 6 months and 75 midwives. 69% of doctors said they would be able to name the muscles, only 25% of doctors said they would be able to do so. None of the doctors could name the bulbospongiosus and the superficial transverse perineal muscle. Midwives did a bit better, a little bit like this room, except for one person. Okay? Over 50% of doctors and midwives said that the levitae ani would be cut during a mediolateral episiotomy. And this is not actually so. Because if you remember that picture I showed you, the levitae ani muscle lies at a much deeper level. Okay? 2 doctors said the external anal sphincter would be cut. And what was worrying is one said the gluteus maximus would be cut. Now, is that possible? Yes? No? No. Okay? Come on, wake up. Right. Now, I'm going to talk to you about the anatomy of the anal sphincter, which today is all about. Okay? And this is really important because those of you who do the pig dissection later on, it's going to make a lot of sense when you understand the anatomy. So here is the anal rectum, okay, and this is a magnified view of this rectangle over here. That's the rectum and the anal canal, and this line here is the dentate line, okay? This is the internal anal sphincter, and you will see that it is a continuation of the circular fibers of the rectum. It comes into the anal canal and ends as a bulbous segment. Okay? This is circular muscle, and when you look at it, when you see on labor ward, it is pale in color, like fish or chicken meat. How many of you have seen the internal anal sphincter? How many of you have seen a 3rd degree tear? None? Yes? What have you seen the internal anal sphincter? Do you differentiate between the internal and the external? So this is what the internal anal sphincter looks like. It is pale in color, okay? And it is a continuation of the circular fiber of the rectum. Lateral to that is the conjoined longitudinal coat, and again you'll be able to see this when you do your pig dissection. And lateral to that is the external anal sphincter. And this external anal sphincter is made up of striated muscle and is red in color. Now, the subcutaneous part of the external anal sphincter lies at a lower level than the internal anal sphincter. Okay? Now remember this, every word that I'm saying has a meaning. Okay? Because you're going to use that in the anatomy later on. So let's look at what this muscle looks like. Now, if you saw this, what would you say? What grade of tear is this? 1st degree, 2nd degree, 3rd degree? 2nd degree. You've been to this course before. Okay? You have? When did you come to this course? Okay, so this is a 2nd degree tear, okay? And you can see over here in this video, that's the superficial transverse perineal muscle. That is an intact external anal sphincter, red in color, okay? And then below that is the pale internal anal sphincter. You'll be seeing lots of pictures, okay? But what I want you to remember right now is the external anal sphincter is red in color. Same as the superficial transverse perineal muscle. and that's why it can be mistaken for the external anal sphincter. Very, very important. Diagnosis is just as important as the repair. So that, in fact, is an intact external anal sphincter. And as our friend quite rightly said, what's your name? Lako, yeah. As he quite rightly said, this is a second degree tear. Now, how do you differentiate between the superficial transverse perineal muscle and the external anal sphincter? How do you differentiate? This is what you do. You grab that muscle. What happens to the external anal sphincter when it's ruptured? It retracts, isn't it? Okay? So you get an Alice forceps, you grab it, you dissect laterally, and here you will see the yellow ischioanal fat. That's how you know that it is the external anal sphincter. Okay? Very important point to remember. Because when you are repairing your third and fourth degree tear, you need to do your dissection. Okay? So you need to differentiate between external anal sphincter and the superficial transverse perineal muscle. Is that clear? Okay? Tip number 1. Now I want you to focus on what I'm saying rather than taking pictures. A lot of you are taking pictures, which is fine, but just remember that you need to concentrate. Okay? So external anal sphincter is red in color. Now the next thing to remember is, what does the internal anal sphincter look like? Like I said, it is pale and looks like fish or chicken meat here. That's the conjoint longitudinal cord, and that's the external anal sphincter, the arms of which are retracted. Okay? So you can see here, just a bit of dissection for you to show you the internal anal sphincter. Okay? And that's the conjoint longitudinal cord. Okay. So, now I want you to tell me, when you go to labor ward and you look at the big dissection, what does the internal anal sphincter look like? Fish, chicken, what did you eat last night? Internal anal sphincter is what color? Chicken, okay? And the external anal sphincter? Beef. Okay, that's fine. I'm happy with that. Okay? So you now know the difference between the two. Okay? Now I'm going to tell you a little bit about what the sphincter looks like when you're doing a scan. And the scan is performed by putting a probe into the anal canal. And when we do that, we focus on 4 levels. One is the puborectalis, deep, superficial and subcutaneous. You can see that probe is in the anal canal, and this is what the image looks like. So in the middle, you have the probe, yeah? And just outside that, you will have the subepithelium. Oh, that's awesome. I don't know if I can transfer. Okay, so let me take you through it over here. In the middle, you have the probe. Yeah, in the middle you have the probe, you have the subepithelium on that, internal anal sphincter, conjoint longitudinal cord, and the external anal sphincter. Okay, you remember the anatomy? Internal anal sphincter, conjoint longitudinal cord, and the external anal sphincter. Now let me take you for a journey through the anal canal. First you have the puborectalis. You remember puborectalis I told you about? Yes? That's the puborectalis. It forms a sling around the anal rectum, and you can see that over here, puborectalis. Next we come to the deep level, and there's a difference between the male image and the female image. What's the difference? What's the difference? Can you see that? In the female, there appears to be a defect. Okay? Here, can you see this? Yeah? Whereas in the male, it is a complete circle. Is that clear? Okay? Now the reason for this is simple, okay? In the female, the external anal sphincter is short anteriorly compared to the posterior aspect. So if you are imaging, there appears to be a defect, whereas in the male, it's a complete circle. Next, you come to the superficial part and you will see it's completely formed. And then when you come to the subcutaneous part, there is no internal anal sphincter. Okay? There is no internal anal sphincter. So on scan, what does the internal anal sphincter look like? What color? Black. Okay? Whereas the external anal sphincter is hyperechoic. Now you may not be familiar with these images, but just so that you know, because by the end of today, we want you to know everything about the anal sphincter and its damage. Okay? This is intact. You can see completely formed internal anal sphincter, completely formed external anal sphincter. This is the image of a lady who had fecal incontinence. Okay? And you can see that this ring is not complete here and not complete here. So between the white arrows, the internal anal sphincter is not complete and the external anal sphincter is also not complete. Okay, is that clear? Okay, so that's a damaged sphincter. This is an intact sphincter. And those are 2D images. You can also do 3D imaging. Now you will say to me that we don't have these fancy probes. But you do have your transvaginal scan probe, and you can also image the sphincter by putting it on the vaginal introitus here like this. That's a sagittal view. And then over here you will be able to see much better a completely formed sphincter. That's the internal anal sphincter, external anal sphincter, and you can see a defect over here. Okay, it's not complete. This is known as the star sign. You can all do this. Okay? You also have the GE machine with which you do fetal scanning. You can image the pelvic floor, you can image the sphincter, and here you will see a beautiful intact sphincter, both internal and external anal sphincter. And this is someone who has a defect. Okay? You all have transvaginal scans? You all perform? Yeah? So you should be able to do this. So the next time you have your patient and you're doing a scan, attempt to image the sphincter. Now we're going to move on to the nerve supply of the anal sphincter and the pelvic floor. This is mainly from the pudendal nerve, which is formed from the ventral rami of S2, 3, 4. It leaves the pelvis through the greater sciatic foramen, re-enters through the lesser sciatic foramen, and here traverses in Alcock's canal. And it is fixed in this area. Okay? Now let's try and imagine what would happen to this nerve during second stage. Just like the levator ani muscle, it stretches, and that gives rise to what is known as pudendal neuropathy. So childbirth trauma can be nerve damage or it can be muscle damage. Okay? Remember that. And when we say nerve damage, it is this stretching that takes place. The pudendal nerve then enters the perineum and is broadly divided into 3 branches. One is the inferior hemorrhoidal nerve, which supplies the external anal sphincter. This is a misnomer because it does not supply the hemorrhoids. Then you have the perineal branches, and the ultimate branch is the dorsal nerve of the clitoris over here. It's important to remember that when you do your pudendal blocks, you're familiar with pudendal blocks? Yeah? The area that gets anesthetized is this bit, and if you're doing an episiotomy, you also need to do local infiltration. Okay? Now, I'm going to end this talk on the anatomy by asking you 2 simple questions, or 3 simple questions. Which muscles are cut during a medial lateral episiotomy? And I want you all to be able to say this, otherwise I will start again. Which muscles are cut during a mediolateral episiotomy? Bulbospongiosus, superficial transverse perineal muscle. What does the internal anus sphincter look like during acute injury? Pale in color, like fish or chicken. External anus sphincter is red in color, okay, like beef. Whereas the internal anus sphincter is white, pale. On scan, internal anus sphincter is black, external anus sphincter is hyperechoic. Okay, that's the only anatomy you need to know about the pelvic floor and the anus sphincter. Now I'm going to talk to you about the physiology so that you understand how this muscle functions. Okay, and it's quite complex, but I'm going to make it really simple. So when you think of maintenance of continence, it's really complex. For that, you need good rectal compliance. So you need a rectum that distends. You need normal stool consistency. So for example, if you've got diarrhea, you will want to run to the toilet, yeah? You need intact neurological function, and you know what that is. And the ultimate barrier is the sphincter mechanism, which again you're all experts at. So now let's try and imagine that a bolus of gas is coming down, the contents are coming down the rectum, so rectal distension is taking place. When rectal distension takes place, the contents come in contact with the internal anus sphincter, okay? And there's relaxation. And when that takes place, it comes in contact with the dentate line, and then something called sampling occurs. So the signal goes to your brain, and you're able to differentiate whether it's gas, a liquid, or solid stools. Okay? So then what would happen if you got the signal, for example, that it is gas and it is inconvenient, you will try and contract your muscles. Okay? When you try and contract your muscles, colonic accommodation takes place. So everything goes back. However, if it was convenient, what you might do is just relax the muscle and pass the gas. So this is just very simplified. It is much, much more complex, but this is just so that you understand the symptoms that occur during injury to the anal sphincter. So now let's look at the external anal sphincter. This is a striated muscle under tonic contraction. And when we think about the external anal sphincter, you've got to remember that it contributes to 30% of the resting pressure. So your sphincter has got resting pressure, so it's closed, and it has got squeeze pressure. So your external anal sphincter contributes to most of the squeeze pressure. Okay? When you squeeze the muscle, what you're squeezing is the external anal sphincter. Now try and imagine that the stool has come down and you've got the signal to the brain, okay? You've got the signal, but your muscle is damaged. So you've got urgency, but your muscle is damaged. You try and contract the muscle, but it's not contracting because it is damaged. So the symptom will be anal incontinence associated with urge. Okay? That's the damage to the external anal sphincter. Clear? Yes? Clear? Okay. Internal anal sphincter is smooth muscle, and this contributes to the muscle being closed. Okay? Now try and imagine if you didn't have that, all your contents would be coming out, isn't it? Okay? So the muscle remains closed. Now try and imagine if there is damage to this muscle. Over here you can see on scan, I told you that it's a complete ring. If there is damage to this muscle, then there's reduction in tone, and the symptom is passive incontinence or flatus incontinence, because the seal is not there. Okay? So when you think about the anal rectal physiology, the really important aspects are sphincter integrity, muscle function, and neural connections. And you now know that to see what the sphincter looks like, you can do scanning. Endoanal ultrasound scan is the gold standard. You can also measure pressures, and there are different ways of doing that. So you know about the resting pressure, squeeze pressure, and you can also measure nerve function, but we don't do this clinically. This is done in research setting. So EMG studies can be done. So that's all you need to know, that in clinical practice we do not use nerve studies. So to conclude, you need a good understanding of the anatomy of the perineum, the anal sphincter when you're doing your repair. You need to understand the physiology, to understand the pathophysiology. That's why I've taken some time in explaining this to you. There were various investigations that I have explained which are complementary, but the endoanal scan, which I told you a little bit about, is the gold standard. Although you can do other methods when you do not have the endoanal scan probe. However, I would say to you that your colorectal colleagues probably do have the probe with which you can do, and it's just about working with your colorectal colleagues and finding the machine in your hospital. Thank you very much for your attention. And I'm happy to take any questions if you have any, or if you want to ask anything later on. Remember, this is a workshop, it's interactive, and the more you ask, the more you'll understand. So don't sit with any doubts in your head.
All right, so you all understand the anatomy? Yes? Rani, they're not sure, they want you to give the lecture again. No? Okay. So now you understand the anatomy, you understand how the anal sphincter thinks, how it functions. The next thing I'm going to talk about is how to make a diagnosis of Oasis. Do you all know what Oasis is? Yes? So this is the classification that used to be followed. And you can see that third and fourth degree tears are known as obstetric anal sphincter injuries. Okay? So you've heard about the anatomy, and you can see that the anal sphincter, as Rani has shown you, if you have a third degree tear, it will be a tear anywhere from here to here. Okay? So that will be a third degree tear. If it's a mucosa, it's a fourth degree tear. So how common is the problem? Well, in the UK, as you can see, in women having their first baby, the rate is 6.1%. So 6 out of every 100 women having their first baby have evidence of a third or fourth degree tear. If you are not seeing that money, because only 1 or 2 have repaired it, it means that you are missing the injuries. These are occurring, and And what happens if you miss the injury? The woman gets fecal incontinence. And fecal incontinence is the worst thing that any human being can have. And this is what, if we are missing these injuries, this is what these women are going to have later on in life. But if you look at multiples, the rate is low, 1.7. So the first baby is the baby that causes the damage. Yes? How many of you are the first born in your family? First baby? How many of you? So you all have to go home and say, apologize to your mother. Okay? So what is happening? If you look at in the UK, over 1 million premature deliveries, you can see the rate is rising over a 12-year period. From 1.8% 25 years ago to 6% now. Is it rising? No, it's not rising. We are getting better at diagnosing it. 25 years ago, we were missing all these injuries. So they're all blaming me for it. But this is what's happening. We are getting better at diagnosing. Next week, in Vietnam, you'll see it going up like this. Yes? Okay. Now, if you look around the world, look at all the different countries, you can see there's a huge range. On this end over here, we've got Poland, Israel, Italy, very low. On this side, you've got Canada, Denmark, Sweden, Switzerland, very high. Why? Is it the people on this side are missing the injuries? The people on that side are overdiagnosing? Interesting. And this is the rate with instrumental delivery. And you can see Canada is the highest. They have a very high forceps rate. And you can see the rate on the left-hand side. What about Thailand? What is the rate in Thailand? In Vietnam. How low? Sorry? Too many cesarean section. But you also do vaginal deliveries. So I am asking the rate in the vaginal delivery, not in the cesarean section. Cesarean section will be 0. Yes. So if you look at the literature, this is a study done in Vietnam. They found that women in Vietnam have a shorter perineal body. And we know the shorter the perineal body, the higher the risk of injury. So it should be very high in Vietnam. This is the only study that was done. It's a small study, 15 cases, and they found a rate of 3.9%. So it's not that low if you know what to look for. But look at the forceps rate. 100% of forceps had Oasis. This is your study, your country. So let me take you back right at the beginning. So some 35 years ago was the first time ultrasound was made, and this is a study I did. I did the scan before childbirth and 6 to 8 weeks after childbirth. And you can see the image on the left-hand side. Rani has shown you the normal anatomy. You can see the black ring is the internal sphincter, white ring the external sphincter. The same woman, 6 to 8 weeks after delivery, internal sphincter, external sphincter. This is the vagina. The woman is in the left position. And you can see my finger is in the vagina. There's a shadow on the right hand side. Yeah, you can see there, shadow. And you can see the episiotomy cut into the sphincter. See this? So this was shown on ultrasound. But the doctors didn't diagnose it, didn't document this injury. Okay? So at that time, I thought this was occult venous injury, meaning it can't be seen by the naked eye, because I only saw it with ultrasound. And at that time, forceps was an independent risk factor, 35 years ago. So since then, there have been at least 10 prospective studies done, and they found very similar results. They found between 3 to 4 women having their first baby, there's a risk of ultrasound defects. So it means we are missing these injuries. The other important point, similar to what I found, as I said before, is the first baby. As you can see here, 34% in the first, the same woman has a second delivery, the rate is very similar. So it's the first delivery that causes the damage. And it doesn't matter, if you have a cesarean section first time, and vaginal delivery, your rate is even higher of the first vaginal delivery having a defect. So the question now arose, what is meant by this occult anal sphincter injury that I'm seeing on ultrasound? Is it truly occult? That means we can't see it? Or is it there and we don't know what to look for? So when we ask consultants in the UK, how do you classify Oasis? And you can see here that even when the external sphincter was torn, 33% were calling it a secondary tear. It's completely torn, 13%. And when the internal sphincter was exposed, that means they could see the internal sphincter, even more were calling it a secondary tear. Because the anatomy was not understood. Because if you can see the internal sphincter, your external sphincter must be torn. Otherwise you can't see it. So it's a third-degree tear. So you can see the amount of confusion that's been happening when I was being trained. So when you get an injury and you get a third-degree tear, it's going to go all the way through the external sphincter, through the conjoint longitudinal muscle, through the internal sphincter, and a fourth-degree tear through the mucosa. Yeah? But the old classification was not good enough because it didn't quantify the degree of damage to the external sphincter, and it didn't tell you anything about the internal sphincter. So this is why I came up with this new classification. Third degree tear is divided into 3A, 3B, 3C. 3A is less than 50% of the thickness of the anal sphincter. It's this way. Okay? Not that way. Thickness less than 50%. 3B more than 50%, but not involving the internal sphincter. Yes? Good. Sorry. Yeah. And 3C involving the internal sphincter. And 4th degree tear going through the mucosa. Okay? So this is the classification. And the rectal buttonhole tear is completely separate, and I'm going to come back to that later. So this is the classification I introduced in 1999, and is now being used internationally. All over the world, they're using this classification. So you can now compare the results because everyone is speaking the same language. Why do you need this classification? Because if you don't do this classification and you don't identify the internal sphincter injury, the outcome of repair is bad. They have more severe anal incontinence. So until 1999, nobody was repairing the internal sphincter. Until now, they've come and beginning to change this. We also know when we compared 3C and 4 is injury to the internal sphincter. And when you have injury to the internal sphincter, the outcome is worse. The other advantage is, if you use this classification, as you can see in all the studies there, using the classification, you can now tell if someone's had a 3A tear, they got a 3% risk of getting anal incontinence, 3B 4%, 3C 9%, and 4th degree 13%. So you can classify and tell the patients during counseling what the risks are. Right. So far, I've explained to you that one reason is people are not getting the classification right. Yes? But another reason is maybe we don't know what to look for. So when this study was done, and a second experienced person re-examined every woman that had a tear, the third degree tear rate doubled. So it means if a second person does the examination, who's more experienced, you increase your pickup rate. So some 15 years, having coined the term occult anal sphincter injury, I want you to know what is meant by occult injury. Is it just seen on ultrasound, or is it can be seen clinically, but we don't know what to look for? So we asked our research fellow was trained to examine every woman during this time, tear or no tear. Do endoanal ultrasound and repeat the endoanal ultrasound 6 to 8 weeks later. So if you don't see the defect on ultrasound at delivery and suddenly see it at 6 to 8 weeks, that would be truly occult anal sphincter injury. So when we did this study, what we found was there is no such thing as occult anal sphincter injury, because the research fellow who was trained picked up nearly every injury with his finger. That's all you need, your finger. No ultrasound. You'll pick up every injury. Okay? So this is what I'm hoping you are all going to be able to do by the end of today's session. So all these studies that we're talking about occult anal sphincter injury, including mine, 15 years later, has been proven to be not occult, but missed injuries. So ultrasound has taught us what we've been missing clinically. So what do you need to make the diagnosis? I'm giving him a chance to translate. And here he's still talking. You need at least one eye, one and one finger. That's all. And you pick up every injury that you need. Okay. So what is the diagnosis here? I know some of you are speaking Vietnamese, so you can't reply to me in English. So that's why I'm asking you the question. I may not get an answer. You can? What's the diagnosis? Sorry? 3C? 3A? 3B? 4? Why are you all giving different answers? The reason is simple. If anyone asks you what the diagnosis is, you say, no finger, no comment. Okay? You must always ask for the finger, because you need to finger to make the diagnosis. There's the finger. What's the diagnosis? 3A.
Trong rồi đúng không? Ngoài. Trong đó cho trắng trắng lại.
No, we got to talk one language. There's only one language. First, second, 3A, 3B, 3C, 4. There's only one language. We're all going to talk the same. So what's the diagnosis? 3. 3 what? 3A? 3C? So there's a problem now. The problem is, Rani showed you this picture earlier on. She showed you this and she showed you what is normal. This is a normal sphincter. So if you don't know what is normal, you can't diagnose what's abnormal. So the first thing we have to learn is what is normal in life. And this is the problem. Nobody showed me this picture when I was told to go and repair my first episiotomy. I missed all these injuries because we don't know what is normal. So Rani has shown you this. The first thing you do when you see the injury, you describe what you see. What do you see? You see my finger here, and you're seeing a tear going down right to the anal verge. And what's above that? This is the external sphincter. Normal external sphincter. Happy, untouched, normal. Next to it here is a superficial transverse perineal muscle. So you must describe what you see, and then you make the diagnosis. Okay? There you are. Can you see that? This is normal. And if you don't know what is normal, everything is going to be abnormal. Okay. What is the length of the sphincter? How long is the sphincter length?
Anh 3A hết.
How long? What do you say?
Độ dài. Độ dài còn 1 cm.
How long? So if you don't know what is normal, you won't know what is abnormal.
Khoảng 1,5.
Okay? Very easy what is normal. This is the length. From here to here is the length. Okay? This is what is the length. How long is it? Everyone has a mark here. This mark was made after the anal sphincter was invented for you, especially for you. That is the length of your anal sphincter, anteriorly, in the female. In the male, it's the same back and front, up to here, 4 to 5 centimeters. In the female, it's shorter anteriorly, up to this mark. And you must know this. If you don't know that, you won't know where to look for the sphincter. Okay? There you can see, the female is shorter anteriorly. The male, same, back and front. So, we are all walking around with a ruler, you see? That's my finger. 2.5, 5, 8, 9, 10, 11.
Người mà thấp
We
đó
all
thì
got a
chỉ
ruler
dễ.
here first. You need to know this. When you are doing examination, cervical dilatation, you're saying somebody saying 5 centimeters, next person examining saying 3 centimeters dilated. Because they don't know what is normal. You must measure what is normal. Put your finger here and measure what is normal. This is why we're getting all wrong figures. Because nobody is teaching you basics. This is basic information that we should have been taught. I wasn't taught it. So I'm not blaming you. And we did a study. And you can see when we looked at all this, most of them were getting it wrong. All the doctors, qualified senior doctors, were getting it wrong because nobody taught them about this. What's the diagnosis? Diagnosis? What is the diagnosis? You have forgotten what I said. What did I say? You want a finger? Can everyone put finger, please? Hand up. Can you put your hands up? Finger up. I want to see everyone's finger. Can you put your finger up? You don't have fingers? No finger? Put your finger up like this. This is what you need. No ultrasound, this finger. Okay, there's a finger. What's the diagnosis? So you can't see very clearly. So you go to clean, and when you clean, you see in the sphincter, it's got an upper margin, the external sphincter, and a 3/8 tear. See? This is a 3/8 tear.
Bà A.
Okay, what do you see here? Once again, look at it. The full thickness is less than 50% of the thickness. It's a 3/8 tear. See, torn to the anal verge, external sphincter, you can see the upper border. My finger is gone up so much, yeah? So my finger is here. And now you know where to look for the sphincter. The sphincter is down here, only up to this much. What's the diagnosis? So Rani has shown you this. So this lady has had, describe what you see. Finger in the anal canal, torn to the anal mucosa. What's next after the anal mucosa? Internal sphincter. This is internal sphincter. Where's the external sphincter? Where is it? Because the anal sphincter is working round the clock like this, tight. If you cut it, it gets upset and does this. And this is what's happened here. The external sphincter is gone into a deep, dark hole. And you can't see it. But I know it's there because I know what the length of the sphincter is. It's supposed to be that much. And it's not there. So it must be worn down. That's why it's important to know how long the sphincter is. And my finger is up to the second digit, up to here. That's the tip of my finger. That's the rectovaginal septum. That's the internal sphincter, and it's partially torn here. You can see the internal sphincter is torn, the external sphincter is gone in. Okay? I'm grabbing the external sphincter now and pulling it out. And when I pull it out, you can see skin, internal sphincter, torn internal sphincter, external sphincter, that is the capsule, around the external sphincter, and that is the ischioanal fat. Very important landmark that Rani shown you already. If you don't know where you are lost. You look for the ischioanal fat, you know medial to that is a sphincter. Okay? So what do you see here? Here you can see I'm putting the scissors underneath this muscle. This is the external sphincter, it's red meat. And you can see most of it is here. And there's the internal sphincter underneath this, the white meat. So I'm putting the scissors underneath, you can see through it, which means more than 50% is torn. So it's a 3B. The external sphincter is torn. Now I'm going to do something for you. You must never do this again. I'm only doing it for you. I'm going to cut this so you can see what's underneath. See
Cơ
what's
dày
underneath?
vặn của đốt ngón tay.
Internal sphincter.
Ở chỗ này là nó sẽ dày lên này.
And the external sphincter is on the side. There you can see. What do you see? Diagnosis. This is internal sphincter. Chicken, fish,
Từ từ, xong hết
raw
rồi.
chicken, raw fish.
Bà-
Yes. This is red meat,
Bà bê.
external sphincter. Beef,
Ba
pork,
C rồi,
lamb,
ba C rồi.
camel, everything. Yes? Any vegetarians here who don't eat meat?
Nhíp đâu, nhíp đâu.
You don't
Nhíp
eat
vào
meat?
bên ngoài cùng cả.
This is
Hai
cauliflower
bên.
and this is beetroot. Yes? Different color. What do you see here? Internal sphincter. I'm pulling it apart, showing you internal sphincter. External sphincter is torn. Yes? Here you can see the internal sphincter and a very small strand of external sphincter here because it's all torn. So this is a 3B tear. Intact internal sphincter. So now you know where the external sphincter is.
Với
Tip
ba
of
B.
the finger. You can see a bit of red meat here. Describe what you see. Onto the anal mucosa. And over here is internal sphincter. You can just about see it. And this is external sphincter. Most of the external sphincter is torn. More than 50%. So this is a 3B tear. Okay? So here, where do you think the external sphincter should be? The length. Tip of your finger. Okay?
Rách rồi. Hai bên.
That's where the external sphincter should be. But you can hardly see it because most of it is torn here. So because you know where to look for, you'll be able to identify tear to the anal verge. The internal sphincter is underneath, you can't see it. All you can see is a bit of external sphincter. What's the diagnosis? Diagnosis?
Ngoài.
You want a finger?
Finger.
Shout finger. What's the word for finger in Vietnamese? Right? Ôi tai. Ah,
Ngón tay.
no tie. Okay, no tie. Right. So there's no tie. So once you put no tie, what do you do next? You must use your thumb. You do the thumb and your finger, and you do what is known as pill rolling, like this. Pill rolling. Okay? This is called pill rolling. And you do pill rolling to feel for the anal sphincter, like that. And if you do that, you'll then be able to see the different anatomy. See? Intact anal sphincter, conjoint longitudinal muscle, internal sphincter, rectovaginal septum. When you do this, you'll be able to feel where the sphincter is. Okay? So, how do you do a rectal examination? Anyone taught you?
Bên kia có một người biết.
Nobody taught me. They said just put on gloves and find out for yourself. But you've got to have good exposure. You must be able to, first of all, before you do the rectal examination, you must have exposure. You must separate the vagina like this. Then you put your, what's the word? Lookout inside. And then you move from side to side. Because you want to check there is no rectal buttonhole there. And then the last thing you do, as I show you here, is your pill rolling. So if you do pill rolling all the way like this, you can feel the ring of muscle. You can feel whether it's intact. You can feel where it is. Then you know what you're looking for. Okay, let's skip that one. Yeah, so Here you can see the external sphincter. Yes? Looks intact. And if you move from side to side, what happens? You can see for the first time normal intact anal sphincter, and look at the gap here. This is a 3B tear. The external sphincter is torn. This is 3A here, and that's 3B. So if you're not sure, or if you've got both, you always call it 3B. So this woman has got a 3B tear, and this woman was not diagnosed with this injury until the researcher re-examined. So what would happen to her? She would have been repaired like a second-degree tear. She'll go home. She'll still have some muscle, so she won't have incontinence. Years later, she comes back with fecal incontinence. Why? Because the doctor did not diagnose the injury and presents to someone else. She might go to the surgeon with fecal incontinence, not to the obstetrician. So we missed it. The patient doesn't come back to us. So this is why it is so important we spend that extra 2 minutes to make a proper diagnosis and repair the injury at the time of childbirth. We are causing it, we must make a diagnosis. Okay, so that's just another 30-degree tear. That's torn, come up on this side, the 3D tear. So you can see here, the bulbospongiosis, the superficial transverse perineal, and the external sphincter are all the same color. So you can't just depend on the color. You've got to have the extra tricks. And one of them is the pill rolling, and I'll teach you more tricks later. There you can see the white meat. Yes, the chicken and the fish. So that's a grade 3C tear. Yeah, you can see the internal, this is a 4th-degree tear, mucosa, internal sphincter, external sphincter is under my finger. Okay? So, what's that? Diagnosis? Looks intact. This lady was going home. Normal intact perineum. Every woman that has a vaginal delivery must have, what's the word for finger?
Ngón tay.
Not thigh. Finger. Every woman that has a vaginal delivery must have a rectal examination. Looks intact. But if you examine it here, she's had a tear going down here, behind this intact perineum. And we couldn't tell whether it was a 3rd-degree tear or not. So we had to do an episiotomy after the baby was born. When we did the episiotomy, we found there's a 3rd-degree tear. So you will never get a 3rd-degree tear if the vagina and the perineum is completely intact. If it's completely intact, vagina and perineum never get a tear. It must be a cut. So if you don't do a careful examination, you can miss an injury. So every woman that has a vaginal delivery must have a rectal examination. You've got to tell the woman, I need to examine you to check and exclude an injury to the anal sphincter. Okay? Do you all do that? Every vaginal delivery? No. So you've got to start tomorrow. Tonight. What's the diagnosis? Don't ask for a finger, there's my finger. That's just a swab. So you describe what you see. So what do you see? The finger in the anal canal. There is the anal sphincter around the finger here. This is an episiotomy. You can see clean cut episiotomy. Looks normal, yes? Episiotomy. But if you don't do a careful examination and move your finger from side to side, you are going to miss this injury. This is a rectal buttonhole tear through the rectum into the vagina. So you must do a rectal examination, proper rectal examination, not just putting a finger in and out. Move from side to side, feel there, ask the patient to squeeze if she hasn't got an epidural. That's a proper examination. Okay, so this is just showing you what happens when a 3rd degree, when a buttonhole starts, you get a tear in the rectal muscle, the smooth circular and longitudinal muscle of the rectum, and then the buttonhole comes. So here you can see the buttonhole, yes, with an intact anal sphincter. Rectal buttonhole, intact sphincter.
Cái này dễ
What do you
dầu
see
lắm.
here? Rectal buttonhole tear, but 3B tear. So you've got a buttonhole tear and a 3B tear. So you can get both. So that's why our classification is now going to change, because you can get a rectal buttonhole tear and you can get Oasis. It's 3A, 3B, 3C, 4-degree tear. If you have intact mucosa between this injury and this injury, this is called a rectal buttonhole tear. If you didn't have this injury, didn't have this intact mucosa here, this would be a 4-degree tear. So this is not a 4-degree tear, it is a rectal buttonhole tear because it's intact mucosa and a 3rd-degree tear. Okay? So this is the new classification that's going to come out. I'm just doing the RCOG Green Top Guidelines. The first edition was 2015. We just finished the second one. It will be published in the British Journal of Obstetrics and Gynae. We just finished the version, so it should be coming out soon. Okay? Okay, so that's a Green Top Guideline. And the Green Top Guideline, the old one. Sorry, this is nice, and this is the Green Top Guideline, says you must do a rectal examination before suture, any woman. But you need to do it to make the diagnosis. So every woman that has a vaginal delivery should have a rectal examination and a vaginal examination. Okay? Alright? So, that's all I'm going to say. I explained to you that the rates appear to be rising, but it's not rising, it is that we are getting better in diagnosing. And there's no such thing as a knockout injury. If you find a defect on ultrasound, it means we missed the injury. And that to make the diagnosis, you need to do a rectal examination after every vaginal delivery, you need to do the pill rolling technique, you need to know that the external sphincter is red, has a proximal margin, and if you get damage to that, you have urgency and urge fecal incontinence. The internal sphincter is pink, does not have a proximal margin, it just comes like this and thickens, no proximal margin. And if you get damage to that, you have lack of control of wind and passive soil. So the woman will tell you, I'm waking up in the morning, I'm finding my clothes stained, or during the day stained, means you don't have the function of the internal sphincter because it hasn't got the tight seal. Okay? So in the next lecture, I will show you the next step of how to make the correct diagnosis before you actually do the repair. Okay? Any questions? No questions? Oh, there's a question.